surgical techniques and resection of tumor, and it's in orthopedic oncology class. So we'll be talking about margins, the meaning behind them, how to save a limb, and when to go for an amputation. And yes, this all we will be doing while thinking like an oncologic surgeon. For our oncoplast, I'm an oncoplastic surgeon, so onco comes before plasty. So first we have to think about oncology of the tumor, and only then we'll think about the reconstruction. And I'm Dr. Shagun, and I work in Swansea, that is in Wales, in the UK, at Singleton Hospital. So we'll start first of all the question that you must ask yourself whenever you see a patient with a tumor in the limbs, are you, or in the spine, are you removing the tumor or are you curing the patient? And as they say, you must treat the patient definitely, location, intra or extra compartmental, neurovascular involvement. If there is neurovascular involvement, well, if the nerve is involved, definitely it's going away. The, the limb might not be functional afterwards. For example, if it's a major nerve like a sciatic nerve in the limb has to go. Vascular involvement, yes, you can still do the reconstruction using grafts or say saphenous vein grafts. So vascular involvement can be managed, but neurological involvement, usually we have to soft tissue, not bony tumor, then you can go for a wide local excision. You can also go for a compartmental resection, which is very rare now, and preservation of functional and critical structures. And margin goal is again 1 to 2 centimeters or a facial.
Soft tissue tumor excision begins with precise localization and marking. Strict aseptic precautions are essential to prevent infection. Local anesthesia is infiltrated to ensure a pain-free procedure. A careful incision is made along skin tension lines. Blunt and sharp dissection exposes the tumor capsule. The mass is meticulously separated from surrounding tissues. Complete excision is achieved with intact margins. Bleeding is controlled using cautery or ligation. The surgical site is irrigated to reduce contamination. Layered closure ensures optimal healing and cosmesis.
Endoprosthesis, autograft and allograft. And now we'll just run through the slides about them. So pros of endoprosthetic reconstruction, already discussed, gives an immediate stability. Patient does not feel like they've lost a limb. And yes, of course, you can go with an early mobilization. Cons, of course, infection and a mechanical failure, but you have to take care of this by keeping in mind of these complications, and you work towards people who underwent bone cancer surgery, all Americans, but yes, we have to learn from them. They're very passionate about their work, and we should be too. That is how it is. And now, just to end, minimally invasive techniques, robotics, and arthroscopic techniques. We've talked about them previously a lot, not going into the details of it. Just the benefits, gives less morbidity, gives a faster recovery. We all know that. But the limitations are oncological safety concerns and certain tumors. So you have to decide. Now, intraoperative margin assessment, what are the tools we have? One is frozen section, not available in UK, not available in America. It's something that is, I would say, very, very exclusive for Asian countries. Why? Because it is very expensive. Not in Asian part of the world, but in the Western part, it is very expensive. Pathologists are very expensive to hire, unlike in our part of the world, in India and sub all the South Asian countries, very, very cheap. So yes, frozen section is something that can be done in India, so you must utilize that. Interop imaging is something that we do in UK, where we have our Faxitron machine, that is the specimen X-ray inside our theaters.
You remove the tumor, but is it truly gone? In cancer surgery, margins determine recurrence or cure. Intraoperative margin assessment checks tumor borders during surgery. The most common method, frozen section analysis. Tissue is rapidly frozen, sliced, stained, and immediately examined under a microscope. One critical question, are the margins clear? This decision happens in real time. If margins are positive, further tissue is resected. If negative, the surgery proceeds safely. commonly used in breast and head and neck cancers. But frozen section is fast, not flawless. Artifacts and sampling errors can occur. Strong and clear communication is essential for clinical success, because one margin can change a patient's future.